If you've wondered what it looks like to work on the step-down unit, come follow me in this video and I'll show you what a night shift on the step-down unit looks like. So after receiving a report, I usually like to come and read the notes from the physician, notes from the case manager, notes from physical therapy, occupational therapy, case management, maybe notes from the previous nurse with regards to what happened during the shift. You want to familiarize yourself with the plan for the patient care. You want to know what was done, what they're anticipating, who they plan on consulting in terms of maybe the kidney, pulmonologist, GI doctor. You just want to also cross-check what you got from report with what was actually documented in the system with regards to the care of this patient. So I always like to go after my shift report and kind of look through the notes, read through everything for every patient, so that before I even give medications, I also know, hey, if a patient is programmed or scheduled for a procedure, to know what medications to hold or what medications to make sure that I'm actually giving. Let's say, for example, a patient has an EGD, you will be anticipating to give golightly. If a patient is, has to go for dialysis or some procedure, maybe you want to hold blood pressure medications or blood thinners. So yeah, I like going through my doctor's notes in terms of what happened for the day shift on that patient. Typically, after reading through all my notes, I feel like at this point I'm very versed with what is expected of the patient in terms of the care. I now move on now to pull my medications. Now, I am that nurse that loves pulling all my patients' medications at once because I feel like I don't have the time to be going back and forth. And so I love pulling all my patients' medications at the time when I'm at the PCs. Now, this is how the PCs or the medication system looks like. Every cubicle has a medication to eat, and this is me pulling out, I believe it's Lipitor for one of my patients. And after pulling all my medications, I always love to pull out my supplies at once, my flushes, my needles, syringes, alcohol swabs, medication cups, maybe IV lines, whatever I anticipate that I might be needing for administering any medication for any of my patients. And yeah, again, I believe I had insulin or maybe heparin to administer for this night. So this is me gowning up to get into one of my patients' room. Actually, on this night, I had a COVID patient who was scheduled to be discharged for day shift, but they were still anticipating to receive one IV drip, which was a steroid. So it was brought to the unit. So I had to quickly, gown up, administer this medication so that the patient could be out by 9 p.m. of my shift. So this is me gowning up, putting on my mask, my gown, my gloves, and getting ready to go into the patient's room. So once I'm finished gowning up, I now get into the patient's room and administer the medication. So I have to go back now into the medication room to actually prepare my patient's medications. Now this night I had two patients who were actually receiving TPN and lipids, but I'm going to go ahead and prepare the second patient's lipids in terms of priming it and making it ready so that when I go into the patient's room, I just have to hang it, scan it, and hook it up to the patient and kind of let it infuse. So this is me priming my IV line, and this is the lipids guy that I also have to prime and Y side it to the filter for the TPN so that it's actually filtering out what should not be getting to the patient in the first place. So like I said, I had two patients this night who were actually getting TPN and lipids. So after I've scanned and administered the TPN and lipids for that patient, I move on to preparing the third patient's medication. Now this patient was an elderly patient who could not swallow their pills, so I had to crush the pills and mix them up in some applesauce so that it makes it easy for them to swallow and therefore preventing any choking or aspiration. I love taking my time in crushing my patient's medication because I always tell myself if I were the one who had to swallow something that is meant to be smooth and I'm feeling like tiny particles or grains in my mouth, I wouldn't love it. So I always take my time to crush my patient's medications very smooth and very finely. especially if the patient has like PEG tube or NG tubes. Especially, you want it to be very fine so that it doesn't clog the tube. After the medications have been finely crushed, I like to mix it in some applesauce. Most elderly patients who have difficulty swallowing whole pills will love their crushed medications in some applesauce. Yeah, some people might like specifically ask for pudding, but you know, the first line of preference is usually applesauce. So I mix the applesauce and the crushed medications, and for the capsules I get to open it up so that the powder is what is being mixed in the applesauce. Sometimes it can be challenging to open those capsules, you know, so as to pour the content into the applesauce, but at the end of the day it gets done. After my patient's medication have been administered, I now move on to the third patient's medications. Now, this patient is the patient who had the other TPN plus lipids, as well as protonics and IV antibiotics. So at this point, the patient's TPN and lipids were already prepped, have already been primed, and I was moving on to prepare the patient's protonics and the patient's IV antibiotics. It's always time saving to prepare the patient's medication in this way so that you spend less time at the patient's bedside. All you have to do at this point is just take the medication that have been mixed in the syringe together with the vials, which you have to scan before administering to the patient, as well as the bottle and the IV bag for the IV antibiotics, and just scan, which have already been prepped and primed, and all you need to do is just scan and administer to the patient. So doing this in the medication room, I can tell you, saves time in terms of bedside, you know, time that you spend with the patient. But I would typically on a regular night love doing all of this in the room of the patient. But just for the purpose of this video, I decided to make and mix and prepare my patient's medication in the medication room so that I'm not breaking any HIPAA violations or, you know, kind of revealing the patient or anything of that sort. So it is more safe to do it in the medication room and then walk into the room and then scan and administer to the patient. At the time of administering my patient's medication, that is when I go ahead and do my assessment on the patient, you know, listening to the lungs, listening to the abdomen, you know, assessing their skin, looking at how their skin looks like, if they have any wounds, if they are pitting. You want to check if any IV bags are, you know, almost running out to get ready to switch them. So at this point, one of my patient's medications wasn't in the PCU, so I had to reach out to the pharmacist so they could send the patient's medication up. And so because we have a tube system on this unit, typically the pharmacist would tube the medication up to our unit, but not in the case of narcotics or like sensitive medications that would require the pharmacist to come up in person and drop or deposit the medication in the patient's PCs or directly to the nurse. Sometimes also, because we are in a rush to pull out our patient's medications, we might forget to check patient's medications in other places that it could be stored. Maybe in the patient's PCs bin, maybe in the refrigerator, or maybe it's a medication that the previous nurse actually have used and left in the patient's room. So you want to cross-check with the pharmacy to know if the medication was delivered and where it could be. So once that is done, I'll be expecting them to tube it to me or to bring it up in person. So in the meantime, I'm going to move ahead and start documenting. I know most people will be thinking like, hey, I assessed my all 4 patients whilst I was giving my medication. How do I get around to remembering what assessment pertains to what patient? I like to say that with new nurses, it might be a little bit confusing, but when you become seasoned and experienced, or as time goes by, you would learn to, you know, ascertain certain things that you do for a patient, for particular patient. Take for example, you might remember that your patient in TPN, maybe the patient, you know, hasn't pooped, or maybe the patient with the TPN, you will remember that, oh, the patient has some lung issues or like some breathing issues, and you know that you assess the lungs, the patient had crackles, or the patient is wheezing, and you would typically also remember maybe from the conversation with the patient, and you would also remember that, oh, for another patient you guys had such conversation. You remember that the patient was, you know, you had to crush the patient's medications and give to the patient because the patient maybe was an elderly patient. You maybe would remember that, hey, the patient was an elderly patient and the patient maybe had edema. You remember assessing the patient for the edema. So it takes a while to be seasoned in terms of remembering what you assessed for a patient, but I honestly would tell you that sometimes you would forget also to assess something with regards to a certain patient, and you would have to go back into the patient's room, you know, to make further verifications or further findings. So at this time, I was reaching out to the doctor with regards to a clarification on a prescription or a medication for the patient on this night shift. It also coincided with the time when one of my patients was calling for a snack, and you know, because I was already documenting and I was already neck deep into my documentation and I was kind of busy, I had to tell the nurse assistant to help the patient with what they wanted as a snack for the night. So after I was done with that call, I remember that one of my patient's ostomy bag was almost full, and I decided to go change it before the bag exploded. So once that was taken care of, I came back to continuing with my documentation. Typically, the step down unit, we have like in-depth documentation as opposed to the med search unit. You want to open the neuro assessment and you're documenting everything: their eyes, their grips, their sensation, you know, their orientation, everything. Long story cut short, you want to be in depth in all the systems that make up the body of that patient. Now, I love rounding on my patients because, as you know, this is a step down unit and anything can happen or change in any patient at any time. So I always like being, prepared for anything that might happen. So I'm always looking at their vital signs. I'm always checking if they are in pain, if any IV bag is done, looking at their oxygen, asking if they need anything, just making sure that I'm one step ahead of the game. After that is done, I come back now and I continue documenting. Again, remember that there's so many things that you have to document. And on the step down unit, we would document every 4 hours. So that means I'm going to be documenting 12 times, 3 times for every patient. I will document at 8 p.m., at midnight, and at 4 a.m. So for each patient, you are documenting at 8 p.m. your shift assessment, and then midnight and 4 a.m. you're documenting like your reassessment for the patient, if anything has changed or if the patient is still the same. That is why it's going to look like I'm always on the computer, I'm always documenting, or I'm kind of like always busy, being lost at the screen of my computer. So documentation, again, like I said, is very in-depth. You're documenting your I's and O's, IV access. You're documenting pain as well every 4 hours, as well as checking if any new lab results have populated that need further intervention for the patient. So there's so much that comes to, just sitting on the computer and looking at the computer. So you have to be abreast on everything that concerns the patient. If maybe there was a procedure that the patient is scheduled for the next day, you want to make sure that you're actively taking care of what needs to be done in terms of preparing this patient for that procedure. If the patient needed to be NPO, if the patient needed, to stop any blood thinners or blood pressure medications, then you have to keep abreast with that. Now, for this night shift, my COVID patient was discharged, and so the room had to be clean, and I was due to be receiving a patient from the ICU. So this is me taking reports from the ICU nurse. I like to ask in-depth questions, everything that has been done so far, what I should be expecting, what are the discharge plan, what is the plan of care for the patient. So it would look like, this call was a long one, but again, I like to take my detailed report so that I kind of know what to expect. I kind of know what has been done for the patient, and I kind of know what is left for me to be done for my shift, and also know what to pass on to the next shift. So I typically will ask, like, if the patient has gotten any pain medicine, if the patient has gotten any blood pressure medications, what are their current vital signs, if the patient has pooped, what's the plan in terms of case manager, just typically getting abreast with everything so far with this patient. Remember, this patient is coming from the ICU, so probably there have been so many procedures that have been done on the patient, so many things that have been going back and forth for the patient. So if the patient is coming to the step down unit, you just want to know, like, okay, why was the patient in the ICU, what was done, okay, at this point, how is the patient's vital signs looking like. You also want to ascertain if you feel safe to be able to take care of this patient. So you want to be asking all these questions so that you are one step ahead of the game. You wouldn't want any patient to come down on your unit and you are surprised as to, finding out something that was not told to you during shift report. So at this point, I realized that one of my patient's bilateral arms were quite swollen, and the least invasive thing I could do to help the swelling of this patient's arm was to get, pillows so that I could elevate the patient's arm so that the swelling could drain out of the hands. The patient's hands were really, really ballooning. Now, remember that I have gotten reports from my patient that is coming from the ICU. So after, elevating my patient's arm, I decided to quickly take a break so that when the patient comes, I will be ready to, run in terms of the patient care. I already knew what to expect, so I just wanted to be ready when the patient hits the floor. Now, after the patient got onto the floor, I, kind of received the patient. We did a quick skin assessment. And then once the ICU nurse was gone, I had to now assess my patient, listen to the lungs, the abdomen, making sure that everything that was gotten during shift report was the same thing that I see in front of me in terms of the patient. So in the room, I like to always go ahead and just do my admission, documentation in the room, so that if there's anything I need, I can always just ask the patient while the patient is at the bedside. And, if there's something that I further need to do in terms of assessment, I just go ahead and do it whilst in the room. Whilst I was documenting, one of my patients' oxygen was on the low side, so I decided to come and check up on the patient. I knew this was a patient who would, get congested, and so I was getting ready to go in there and do some suctioning for this patient, so that is going to help in the breathing for this patient and help with that oxygenation status. Now, this patient was also on droplet precautions, which is the reason why the patient had like a precaution cut at the door. So I got in, I found out that the patient was really congested and was very coarse in the lungs. So I had to crank up the oxygen first before suctioning this patient, because the patient is already low on oxygen. You don't want to go ahead and suction, thereby sucking out the oxygen which the patient is even struggling with. And so you have to crank up the oxygen before even doing your suctioning. So I was checking to see if the patient's still feed as well was still running and everything was still okay. The IV bags were still infusing. And I also noticed that the patient's mouth was also kind of dirty, so I decided to clean the patient up whilst in the patient's room. I also checked up on the patient to see if the patient was soiled, but the bed chalk was very clean at this point. And just trying to keep the patient clean, keep the patient comfortable. Now, this was a very dependent patient and the patient could not do anything for themselves, so I kept coming back and forth into this patient because I had to help the patient out, because the patient was very, very solely dependent on me. So whilst I was done, I had to use my hand sanitizer before stepping out, and I usually would step out of a patient's room only when I feel comfortable knowing that the patient is out of danger. So once I stepped out of that patient room, I had to check on my other patient to see if they were okay, if they were comfortable, and if their vital signs were kind of stable. After that, now I move on to my 4 o'clock documentation. At this point is again just reassessment. So you already know what's up with the patient, you already know what the previous documentation was, so it's going to be easy at this point to just kind of like update the assessment documentation in terms for this patient. And at this point also we start getting ready for shift change reports. You want to start updating your report sheet, maybe any new labs, any vital signs that had that warranted you to do something for the patient. You actually be writing it down just so that you can relay it to the next shift. And here I was chit-chatting with my co-worker, and we were talking about her previous vacation outing. It was just nice to know that the shift was almost over and it was kind of getting lighter. And at this point, most of the times, because it's night shift, most patients will have just 9 p.m. medications. Very few will have midnight medications, and maybe 1 or 2 will have like 6 a.m. medication. So I'll tell you that night shift is very chill. You don't have family members going back and forth asking you questions. So night shift is more so just documenting and doing what you have to do for the patient. So at this point, I was getting ready to pull out my 6 o'clock medications for my patient. Typically 6 o'clock medication will be like maybe diuretics, maybe their thyroid medication, maybe blood pressure medications. And yeah, at this point I'm already so excited and happy knowing that the shift is almost over. Honestly, this was a chill shift for me, but it's always nice when you're giving that 6 o'clock medication to know that hey, the shift is already rounding. At this point, my hands are looking so cranky from all the gel in and gel out, and washing your hands when you especially change patients when they've pooped, or maybe you empty a Foley. And yeah, this is me just getting my syringe for my heparin sub-Q for my patients, and I'm so excited because the shift is almost over. Well, not so much over because I still had to restock some gloves in some rooms. And so at this point, the shift is almost over. If you're new to my channel, please do consider liking, sharing, and subscribing, where I talk a lot about the PCU or step down unit. There's going to be subsequent videos coming up. If you like such content, please do not forget to join this bubbly family. I'm so excited. I know you cannot tell that I'm almost running to my car. At this point, I am so getting ready to go just take a shower, to sleep, and get ready for the next night shift, knowing that I'll be having the same patient. It's usually easy to just continue taking care of these patients. Thank you guys, and I'll see you all in my next video. Bye.